Welcome to the Health System CIO show. I'm your host, founder, and editor Anthony Guerra. On today's episode, I'll be speaking with Dr. Alex Towbin, Associate CMIO with Cincinnati Children's. Dr. Towbin, thanks for joining me today.
Thanks for having me on the show.
All right, great. You want to start out by telling us a little bit about your organization and your role?
Yeah, so I work at Cincinnati Children's Hospital. It's a tertiary or quaternary, depending on how you like to classify hospitals, freestanding children's hospital located in Cincinnati, Ohio. I serve as associate CMIO for the organization, helping to lead enterprise imaging.
Perfect. Very good. All right. So you wrote an article recently where you talked about PACS 3.0.
Yeah.
You defined it as workflow-centered intelligence, gets embedded into the imaging environment. Just tell me about sort of the genesis of that article and what you've been seeing or doing and why you felt it was sort of enough going on there for it to be defined as kind of another evolution.
Yeah, and do you mind if I go through the
Not at
other
all?
phases of the evolution?
Go ahead.
And so I started recognizing this over the last several years, looking at some of the different medical conferences and seeing the offerings that technology vendors were bringing to the shows.
Mm-hmm.
And it really started to feel like there was a shift in what the industry was presenting and how the industry was thinking about using technology, particularly around imaging. And so going back through the history, it started getting me thinking of what is going to be that next generation of PACS in particular, the radiology viewer, but all imaging viewers overall, and how people would interact with them. And so that became the genesis of it. And it got me thinking if we were going to move to the next generation, what state are we in today? Which generation are we in, and what has characterized the different things? And that has been a fun exercise talking through with different people in the industry. Everyone has a little bit of a different feel. The way I see it is that the first generation of PACS was built around turning a film to a digital image. And so moving from those film-based workflows to the digital workflow, and what that meant was starting with digital machines that were creating those digital images and sending them from the machine to a computer somewhere for someone to look at. And those were often machines connected directly to computers connected directly to a modality like a CT scanner or an MRI scanner. And they were, in those earliest of generations, proprietary based, not using standards. And so data was flowing from machine to computer. And those worked well for a period of time. And these were at the time when hospitals had maybe one CT scanner, maybe one MR scanner as their departments were growing. And so it could work well because it was a single vendor and a single radiologist reading, and that scanner and that radiologist was not being overwhelmed with volume. As the complexity increased within departments and hospitals started purchasing more and more CT scanners, MRI scanners, and other modalities became digital. And it no longer made sense to connect a single computer to a single machine. That really limits the ability of then the humans to do work. And so that began the push towards standards, which is what DICOM grew out of. And the end of the first generation of those PACS became bringing standard-based imaging to a single computer. And so that was the beginning of first generation to the end of first generation. The second generation really launched, I believe, in the early to mid 90s with internet and internet-based technology. And the phraseology that was hot then was a web-based viewer.
Mm-hmm.
And so what I see as the impetus of generation 2 of PACS was distributing images. It was taking images from across an organization or an institution and sending them to many different places. And so this democratized imaging. It helped the viewers to be available across the enterprise. So you could have that enterprise viewer launch images different than a radiology viewer. It allowed cardiology images to be transmitted as well. That push helped to let radiologists eventually work in different hospitals. So we enabled mergers and acquisitions to work in radiology and other specialties. And eventually started to enable the work from home movements, teleradiology practices, all of those. By the end of the second generation, we're talking about cloud-based technology, so distributed storage, not just distributed networks. Those images are available everywhere, and speed matters to be able to send images to different places.
Mm-hmm.
All of that allows radiologists and other imaging specialists to take care of patients around the world, and to do so from a common location. And that's at the end of generation 2. And now we're dealing with a different problem. There's a shortage of radiologists. There is increasing burden, increasing numbers of images being produced by the machines for radiologists to be able to handle. There's lots of data that's being generated from those images, not just the interpretation, that's not just the picture itself and not just the radiologist report, but other types of measurements. All of that type of data flow can happen, but it's fairly clunky. Mm-hmm. And so I think that's where what I'm seeing in the market starting to respond to that is that concept of workflow intelligence, of how do we start positioning data and insight in front of the human to be able to work more efficiently, to do their tasks with less and less burden, so that they can get through their workday. Instead of being overwhelmed with mouse clicks and keystrokes to have data move from an image to a text-based report, can it happen automatically? Can we bring more smart intelligence, whether it's artificial intelligence or informatics work, to help that data flow more efficiently?
Yeah, very, very interesting. So there's a couple issues you mentioned,
Yeah.
sort of macro issues. One is massive amounts of volume. Um, the population's getting older, right? People are getting older. Um, and I don't know what your thoughts are around the ordering of images. If you feel like in general, it's sort of uh, we're not going to get in trouble for ordering the image, so let's just order it anyway. And
Yeah.
yeah, there may be one over there or over there, but I don't know, if they took the right image, and I don't know if we can get it, and maybe I want to see one up to date anyway, so I'll order it. So I wonder on the front end side, some of those macro trends that may be contributing to ordering excesses, and I don't know if AI is going to make that better or worse. And then a shortage of radiologists. So I don't know if we're
Yeah.
just not getting as many people going into radiology, maybe because it's a chicken and egg thing where the volume is up so high that the quality of life goes down, then people stop wanting to become radiologists. So you have fewer radiologists and more of a burden on those who remain. So let's take that a little bit first, that whole
Yeah.
volume side. What are your thoughts about what's going on there?
Yeah, I agree with you, and the data backs it up. And so, for example, we know that radiology volumes are increasing dramatically and have increased dramatically. We also know that the number of radiologists, is steady to declining. It's definitely not increasing. According to Health and Human Services data, the demand for radiology services exceeded the capacity to deliver them in 2023. And that's the exact time when we start seeing radiology practices get behind. Turnaround times that used to be measured in minutes are now once again measured in days or weeks in some practices. And it's because of that mismatch. There's so much volume and not enough people to work through the volume. And so then the why is some of that happen? Some of it is that an aging population needs more healthcare, for sure. I believe that some of that is that radiology has done an incredible job over over the years.
Hmm.
The PACS 1.0 to 2.0 and 2.0 to 3.0 have helped to transform medicine and healthcare delivery. A CT scan that used to take 30 minutes to perform and 3 hours to process can be done in seconds. A radiology result that used to take weeks can also be output in minutes, and they're highly accurate. And so radiologists often are able to give an answer to a question faster than a lab result can come back, faster than a consult can appear a consult can go to the ER to see a patient. And so we can help, particularly in ER imaging, to give a yes or no answer that helps to drive what the emergency department needs or other people need very quickly. And most of the time we can do that at a reasonable cost. Comparatively, compared to other things. So that success, the power of a yes/no answer, has really helped to push the ordering practices towards radiology. But now service is going to start to decline again, now that there's a mismatch. And so I do wonder if that will continue as service quality decreases, not the quality of the read, but the timeliness as that decreases, if that will impact the volumes. These other things in a PACS 3.0 world will help with efficiency and may allow radiologists to do more work in less time or have more output, but that can also just lead to burnout, and that's not the goal either.
So there's, and I think you mentioned this in your article, there's kind of AI working in two areas in radiology. It's actually evaluating the images, which is unique to radiology, where it's evaluating images. And we could talk about that for a minute, whether or not that can help with sort of throughput and processing. If there's perhaps a portion of the image volume that can just be handled by AI, the simpler stuff maybe. Um, and then there's the AI that all of us are trying to figure out, which is just efficiency optimization, workflow optimization, separate from specifically reading an image. So in radiology or in imaging, you have both types of
Mhm.
AI. That's a lot to master. That's right. That's a lot of workflow. That's a lot of change. That's a lot of integration. That's a lot of experimentation. So your thoughts around that sort of two angle or two avenues of AI in this area?
Yeah. So the United States FDA clears a number of different types of artificial intelligence, and then there's a lot of artificial intelligence that they don't currently have domain over or don't currently clear. The type of AI that gets a lot of attention is diagnosis and detection. Detection says there's this finding here. Diagnosis says this finding is this diagnosis. And so that's the stuff that gets a lot of attention. There's not a ton of that that's implemented today, even though there's about 1,000 FDA cleared medical software devices. Some of that's duplicate. So there's many different, for example, there's many different detection models for pulmonary nodules, as an example. But any one practice may just have one of them or
Right.
zero. So that type of diagnosis detection is the one that gets a lot of attention. It's not the most common type that's approved. Triage algorithms are the more common type of approved algorithms. Those say this patient should be higher or lower on a list, essentially, and can help to manage when you have a backlog
Mm.
who needs to be read next, or identify certain conditions so that there's a more timely diagnosis. And then there are other types of FDA cleared artificial intelligence to improve image quality, to do 3D processing. Many of the artificial intelligence tools we use today are not cleared and will probably never be cleared. A great example of that is ChatGPT. And I'm not saying that ChatGPT or Claude or those types of public facing large language models should be used in a day-to-day clinical practice, but it's just an example of a tool that's out there. Those tools can help to build other tools to drive workflow. And so an example would be building a website that helps to provide a calculator for a condition. And the calculator may be something simple like dividing two numbers. But if you're doing it frequently and you're always pulling out your phone to type in the things on your calculator, if we can do that in a little bit more efficient way, it can do that simple calculation. And there's not at least today, there's not a need to have that type of tool FDA cleared when it's homegrown developed. And so that's the example of types of things. There are many other types of artificial intelligence that probably don't need to be FDA cleared that vendors could implement. An example in a PACS would be something like a hanging protocol or display protocol. Those say, if I have an MRI, what sequences do I want to be positioned in the first position, the second position, the third position, and how do I want the comparison studies to be laid out as well, similar in the first position, second position, third position. AI could do those things. It's not performing diagnosis or detection, but it makes our job easier.
All right, very good. So let's again, our readers, the people we're trying to help are the enterprise IT folks, including the
Yeah,
CIOs and the folks like yourself, the CMIOs. You have a foot in each camp, right? You're in
yeah,
enterprise IT and you're a practicing clinician, like most CMIOs probably. Um, so let's start with this. And I find enterprise imaging fascinating. My observations of it, I've been looking at it for a number of years. I thought about 4 or 5 years ago it was really going to explode. It sort of didn't, at least from my
yeah,
perspective. I even thought recently it was going to really explode, and it just isn't. It just doesn't happen. Like it happens occasionally at a large institution. You will be doing a major enterprise imaging initiative, but it's infrequent. It's certainly not like, and I know this was policy driven that everybody went on EMRs in 2010. That was policy driven for the meaningful use money. Um, so that obviously didn't happen around imaging, and it hasn't happened naturally. It's fits and starts, but some people do take it on fully. What do you think is the average state of affairs in most health systems when it comes to imaging?
yeah,
And I'm wondering, if I'm an enterprise IT executive, I've got a lot on my plate, and I want to deal with problems. I want to lead. I just don't want to do what people are asking. I want to do that, but I also want to lead. I want to understand where we're operating suboptimally and where we should be doing something. And maybe I want to try and drive change or educate the operations folks about what could be or what's going on over here. So what's your thought on sort of the state of average affairs? And I'm really looking for your advice here for your colleagues as to, here's the typical state of affairs, and if this is what you have going on, you know what, you're okay. Like you're operating at about the average. You have some image exchange, you're functional. But here's what
yeah,
it could be. Here's what you could be doing. And then there'll be places where you would say, hey, if this is what you look like, you're not even close, right? You're not close, and you're operating in PAX 1.0 or whatever we were calling it, right? You need to at least get to 2.0, maybe not 3.0. So I'm going to ask you there. What are your thoughts there that you can give our listeners?
yeah. Thank you for that question. Enterprise imaging is hard, and I think that's the first thing to say. It's hard because there's not a lot of tools to help you to make these end-to-end workflows. There's still a lot of inventing going on, or MacGyvering tools together to make it work. That type of process is fun, but it's not a place everyone wants to be in. That said, I think many institutions, organizations are doing enterprise imaging to a good degree. Examples of places, or of types of images that are being obtained. Radiology is always a part of that. Every place is doing cardiology, is doing cardiac imaging. There's echoes, there's cardiac caths that are happening. Those are being managed somehow, somewhere. The next ones are in many places. I would imagine that anyone who's doing eye care is doing imaging. Whether they they go to different systems or it's in a single viewer, that's a different story. But everyone is doing imaging in eye. If you have dental, everyone is doing imaging in dental. Point of care ultrasound is a big thing at many organizations, and many organizations are already doing that. So I think imaging is happening across the enterprise. The place that places may or may not be doing it, or where they may be struggling, would be medical photography in particular, using mobile image capture. A lot of organizations do that and incorporate it into the EMR directly, but it's not done in a way where the images are easily accessible.
Hmm.
And another one that I would guess every hospital is doing today is in peri-op. Whether they're storing those images is again a different question, but they're capturing them through the endoscopes and colonoscopes and all the other types of laparoscopes. Those images are going somewhere. The question is, are all the images going into one place at an organizational, some enterprise imaging archive? And then are they able to be distributed across an enterprise viewer? That's where it starts getting more challenging.
Yeah, and
And
go
that's where
ahead.
that
I'm sorry.
MacGyvering happens, where you have to try to get it all together to make the data work in a way. And there's a lot of challenges with that.
Yeah, you mentioned MacGyver twice.
Yeah,
I remember watching that when I was young.
yeah,
When it came out, when it was actually not even a repeat. So that was a great show.
it was a
Um,
fun show.
it
I
was.
enjoyed that one too.
Um, so I think what I'm trying to ask you here is when is care impeded, and it doesn't have to be. An image isn't available, but it should be,
Yeah.
because as a organization, you're not at least at that minimum level. Like in your mind, Dr. Tobin, you've got a sort of minimum level stakes to play, right? I don't need you to be advanced, but I don't want you to be inhibiting care because you're not at this sort of average operating level of a patient. Like a patient comes in and they had an imaging done at your other hospital, but we
Mhm.
don't have it, right? Maybe that's not good enough anymore. So what are the tells, the operational problematic tells that impede care that you could tell us, hey, if you've got this scenario going down, it's not good enough anymore, right? So where's sort of good enough, and then where is sort of cutting edge?
I think all the things I described are good enough. Image sharing is a challenge, and I want to recognize I'm coming from a place that is a quaternary care center where we're having patients referred to us from around the world. So what I need in that setting is different than what a rural hospital needs, where patients may be more likely to be referred out rather
Hmm.
than referred in.
Hmm.
And the cost of those types of software is different, and the ability to deliver on just providing any care for a patient can be impacted from those types of software procurement. So I do want to be careful in saying that that's substandard. The basic standard of care is that, in my opinion, that the specialist who needs the image has ability to see the image. Um, and I am talking about within the specialty. And so something like a radiology image can be used across specialties, but the radiologist is the most, my biased world, the most important person to be able to see the image. Then the next most important would be the person who needs to consume that image in a different way. So maybe a surgeon or a pulmonologist or a gastroenterologist needs to see the image in a second way. But you start moving down the line in that order of importance. And I'm phrasing it that way because the more access to information you have, the more you see how beneficial it is. So for me as a clinic, when I'm practicing clinically, it's really helpful for me to see the medical photograph from the ER or the endoscopic image from the operating room. That allows me to be a better doctor, and allows me to take better care of my patient that's sitting in front of me from the radiology side. So the more information each of us have, the better we are, assuming that we can consume that information efficiently. And the more as your information increases and your ability to consume it increases, your perception on standard changes.
Right. And we still have discs out there, right? I mean, we still have patients walking around with discs, and we still
We
have
do.
clinicians getting discs and not being able to get to see what's on those discs for different reasons. And we
And
have,
many hospitals receiving those discs don't have disc players
right, that's what I'm
or
saying. So,
readers. Yeah.
so I brought you a disc and you can't read the disc, and
Yeah.
nobody in this room thinks we should have a disc at all, but I've got it and you can't see it. And there's couriers driving around between health systems on, with discs and
Yeah.
whatever. Um,
So
that's
with image sharing in particular, that does get to the challenge of who pays for it, and I think that's an interesting ethical discussion. So that rural hospital that's only sending their data out, should they be purchasing a image sharing platform, or should the receiving hospital be the one paying for it? And you can make a good argument that the receiving hospital should pay for it. But what if sometimes as a sending hospital you send to hospital X and another time you send to hospital Y and another time to hospital Z? Then do I need to have three different platforms in my hospital to send to? It becomes a little bit of a logistical mess, even though there are technological solutions for it. And so that's why I struggle with from the ethics side of it and the how to pay for it side.
hmm
What we've tried to do at my organization is say, if you have anything, any type of software, send it to us and we'll receive it. And we will come up with a way to make the data flow into our side, no matter what system you choose. If you don't have a preferred vendor solution, we will offer you the solution that's our preferred one. And if you don't want any of them, we'll give you a way that you can do it through the internet. That way through the internet is the slowest, and it requires a lot of individual work to first download the images, then upload them, and so it takes technical know-how a lot of times, and that's not always not always present based on the staff who's on site at the time of day that the study is that is being sent. It's one thing for a long-term referral. It's a different thing in a trauma setting.
right. And the effects of these challenges are both clinical and
Yes.
financial, right? Because you have cases that are canceled, appointments that are canceled because we would have moved forward, but we don't have access to the image for A, B, or C reason. We're going to have to cancel it. And, sometimes, a lot of times, clinical issues have a time issue with them. Better, faster is better, right? So,
And it adds to the other problems we talked about earlier. So the other solution for that, and so one solution could be canceling a procedure. Another one would be doing more imaging, and that costs the
right,
patient more
right.
money, and it leads to that burden of workflow. And in many cases, that study is not needed. It's just because we can't get the other piece of information, right?
Yeah,
We're not providing new information. We're just repeating old information.
yeah, and I'm not sure how the insurance companies handle that. So if they
Yeah.
just paid for an image across town and now you're over here and, I don't know if they're interested in paying for it. They say, go get this one. I don't-
I'm sure they're not interested in
yeah.
it. And when they pay and when they don't pay, there may be variation based on time, like time between studies. But agree.
All right. So what is your best advice for those you've got those roles. You've got the CIO who's going to be leaning on their CMIO um, for this kind of guidance of what needs to be addressed. You've got
Yeah.
CMIOs who may be in that kind of position I described before, where they are both receiving requests, so to speak, from the departments and should be leading to a certain degree. So where again, sometimes not much happens around enterprise imaging, and sometimes it's a organization-wide initiative, all in. We're doing
Yeah.
everything, and to me, that's got to be based on the CMIO's leadership and guidance. At least I would think it is. I would think it's not going to go anywhere if the CMIO isn't championing it. And I know they probably won't champion it if they haven't either received that groundswell of interest or built it. I don't know. What are your thoughts around that?
I agree. There has to be a champion, it doesn't necessarily have to be the CMIO. It could be an associate CMIO. It could be someone who's leading imaging IT in a different title or role. But someone has to champion it and push it forward. A lot of times it is saying what's the value to the organization, and I think there are both hard dollars and soft dollars that can justify it. Hard dollars, it depends on how different organizations capture dollars. So I want to recognize that. But an example, point of care ultrasound can provide a revenue stream based on billing. And enterprise imaging can enable that. And you can't bill for point of care ultrasound unless you're storing images and providing results on them. That's exactly what enterprise imaging solutions help to enable. Eye care imaging is the same thing. Eye care imaging is something that's easy to capture revenue around and benefits patients. And so those two things will help to pay for enterprise imaging by themselves. You start throwing other types of data around, whether it's pathology imaging, or tying in peri-op or others, and it does make sense. The other thing that enterprise imaging can help to do is reduce that workflow burden, but not using the artificial intelligence type solutions that we talked about at the beginning, but just good informatics solutions. And so what we've seen in our organization, whether it's implementing point of care ultrasound, eye care imaging, perioperative imaging, every place that we go, we reduce workflow by somewhere between 60 and 80%.
Wow.
And that's mostly from standard technology like a DICOM modality worklist. So instead of you having to type a patient name, a medical record number, and a procedure, it just flows. We can automate billing practices. So instead of making sure people do something, they drop the charges or post the charges correctly and do the correct charges for the correct procedure, we can automate all of that. So those types of efficiencies in a system can help to improve consistency of billing and reduce work effort. That burdensome effort. That it's important for data integrity, but it doesn't need to be there's no value of the human doing it. In fact, there's more value of a machine doing it because there's less likely to be a mistake. And so those types of things are I think those are both the hard and the soft dollars to push enterprise imaging forward. But because it's hard, you do need a champion to help to figure out this is how we're going to do it, to help to drive some of the decision makings, to say we're going to automate billing, we're going to drive reporting in this way, we're going to prioritize ophthalmology imaging or dental imaging, and because imaging comes from everywhere all at once.
Yeah, well, my final thought, and then I'll get yours, is that, I've been using the phrase lean in a lot,
Yeah.
that I think IT executives, enterprise IT executives need to lean into different operational areas and really soak up the knowledge and understand the workflow, and then figure out how they can help with technology, if they can help. And this seems to me one area that they should be leaning in, and just being very open to supporting the initiatives and understanding the pain points. And because it's hard, but it seems certainly like one of the areas that are absolutely worth spending some time and money on. So I'll leave you with that. I suspect you agree, but what's your final thought?
I do, yeah. And so two things. One is it's been estimated that imaging represents about 90% of medical data, of healthcare data. Imaging is 90%. And with pathology coming online, that number will grow pretty dramatically. I mean, it's already at 90, so it can't grow a whole lot more, but pathology imaging is a massive. The next thing is if you want to learn more about imaging IT, the value of imaging IT, or the value enterprise imaging can bring, whether it's with artificial intelligence or without, the Society for Imaging Informatics and Medicine, SIIM, is a great place to go. That's the kind of place where physicians, administrators, IT professionals, vendors, all go to talk about imaging. And I haven't highlighted it enough, but it's across all specialties. It's not just radiology that does imaging. It's all these specialties. Every specialty produces images, and every specialty consumes images in some way. And so to find ways to do that easier, to break down barriers, is important.
All right, Dr. Tobin, listen, this was wonderful. I'm glad we got to catch up again, and I
Yeah.
certainly want to check in with you again down the road and see if we've seen that explosion that I hope we see with enterprise imaging. But great to talk to you as always. So thank you.
Thank you. Thanks for having me on. It's always a fun conversation.
Have a great day.
You too.